Hey, good morning, everyone. Our official start time's 9:05, so we're going to wait a few minutes here. Good morning, everybody. Looks like most people are here. I wanted to welcome everybody to the December 2022 Health Insurance Marketplace Advisory Committee. I'm Craig Anderson. I'm the acting chair. And can you move to the next slide, please? Thank you. I did want to welcome everybody. And before we do a roll call, I just wanted to mention that there's been a lot of activity since we last met. Obviously, we had an election, which brings with it some changes in our legislature, new governor. So we're going to hear today, if you've seen the agenda, you'll see that we're going to hear today from both the Oregon Health Authority about their legislative concepts and the DFR, which should be interesting and have some impact on us. And we also will hear from Gina Sherrick, who will give us her perspective on what's happening federally as well. And then, as you all know, as many of you may know, the public health emergency has been extended till April, but there's still a lot of activity happening around redeterminations and what's going on with Medicaid. So we'll hear about that as well. And then lastly, but not least, we're in open enrollment, and we'll hear from the marketplace team about what they're seeing with open enrollment. So with that, I think I'll ask Chicky, if you don't mind, to go through the roll call.
Good morning, everybody. Chicky Flowers. I am the director of the Oregon Health Insurance Marketplace. My pronouns are she, her, hers, Shakanya. And for visual purposes today, I am wearing a dark brown sweater and I have long dark hair. So for roll call today, if you are here in the meeting, can you please let us know if you're joining by video and or by phone? So for example, Chicky Flowers, I am joining by video and audio through my computer. However you want to go about it, so that will help us track however you are joining today. So first off, Craig Anderson.
I am here and I'm joining by video and the audio through my computer.
Thank you, Craig. Gladys Butwell.
Present, joining by cell phone. She, her, pronouns.
Thank you, Gladys. Ron Gallinat.
Here and attending via my laptop, video and voice.
Thank you, Ron. Maribeth Guarino. I believe, sorry, my apologies. I believe Maribeth did send us an advance heads up that she is on vacation today. Paul Harmon.
I'm here and joining via video and computer audio.
Thank you very much, Paul. Lindsay Hopper.
Good morning. I'm Lindsay. I use she, her pronouns. I'm joining by Teams on my computer with video and audio.
Thank you, Lindsay. Kathleen Jonathan. Ines Kemper.
I'm here and I'm present by video and audio.
Thank you, Ines. Joni Moore.
Present with phone audio.
Thank you, Joni. Lindsay Shurahama.
Present and attending via my video and audio.
Thanks, Lindsay. Holly Sorensen.
Good morning, I'm Holly and I use she, her pronouns and I am tuning in via computer audio and video.
Thanks, Holly. Director Andrew Stolfi. Okay, I believe Director Stolfi, it is also December legislative days and he did mention he may be coming in and out, so he may be able to join us later on. Om Sakinai.
Good morning. Yeah, presence. She, hers, video, audio.
Thank you, Om. Drew Tara.
Good morning. Joining via laptop and he, him pronouns, and obviously on video. Or not obviously, I am on video.
Thank you, Drew. Nishoba Temperley.
Present. I'm joining via Microsoft Teams for video and audio. Thank you.
Thank you, Nishoba. And that Chair Anderson completes our roll call.
All right, thank you. Great to see everyone. We can move to the next slide. As we do with all these meetings, we like to remind people about the protocols and just to remind everybody that the Marketplace and the HIMAC are committed to a safe and inclusive meeting for all attendees, and please feel free to speak up and ask questions. Really encourage that. The participation is very helpful. And then lastly, if you see anything that you find unacceptable, please notify Chicky. Next slide. And if you would please be on camera as much as you can and mute your speaker when you're not talking. That would be helpful. And if you have any questions or comments, please raise your hand in the virtual chat. We'll keep track of that and make sure we get to you. And there is the option to turn on captions if that's necessary as well. All right, so our first order of business this morning is an approval of the minutes, and those were sent out twice. They were sent out shortly after our last meeting for people to review, and then Dawn sent them out again earlier this week for any other edits that people might have. Before I ask for a motion to approve, any discussion about the minutes from the last meeting? Any questions or comments? Okay, not hearing any. Could I get a motion to approve?
Ron Gallinat, I move to approve the minutes as presented.
Thank you, Ron. Hey, can I get a second?
Holly Sorensen, I'll second that motion.
Thank you. And if all of you would either say yay or nay in the chat, we'll just collect those as well. So that's the easiest way to do that. All right, thanks everyone. So our first topic this morning, we have a guest speaker, Gina Sherrick. She's substituting this month for Stephanie Kennan, and she's going to give us an overview of federal health policy updates. So thank you, Gina. Take it away.
Thanks so much, Craig. I'm happy to be with you all. You have a downgrade with me over Stephanie here, but appreciate your time this morning. First of all, it's just as far as, the lay of the land post-election goes, control of the House of Representatives did flip to Republicans, as I'm sure most of you are aware, but without the sort of much discussed and hyped up red wave that was widely expected. There is currently some measure of strife within the GOP in the House pertaining to the House Speaker's post. And I'll get to this in just a moment with a little more color as far as, sort of the happenings at the end of the year. But the current minority leader, Kevin McCarthy, is very much trying to obtain the House Speaker post. And so he's sort of got his work cut out for him trying to handle his hard right conservatives and keep them happy enough to vote for him for Speaker. In the Senate, we now have a confirmed clearer picture after the Georgia runoff earlier this week, with the Democrats not only maintaining control of the Senate, but also picking up one seat. So, I think we're in for probably a relatively wild 2023, just as we hit 2024, we start to go into a presidential election season. And so 2023 is probably where the bulk of any sort of work will get done in terms of the next Congress. As of, this morning, this seems to be changing by the hour, but current sort of end of year happenings, they are pretty far away in the Senate in the House as well, from Republicans and Democrats agreeing on a top line number for any sort of appropriations bill to actually materialize. So right now we are looking at the likelihood of a short-term continuing resolution past December 16th, when the government is scheduled to run out of money, being passed. And by short-term, I mean very short-term. Perhaps a week to December 23rd, perhaps a couple of weeks to December 31st. At this point, it's really murky as far as trying to get any clarity around that. And after that is even murkier, with House Republicans and nearly all of the Senate Republicans, sort of pushing for a continuing resolution that will run into early next year. Again, we're unclear at this point if early next year means January, if it means March. There's also some buzz that Republicans are pushing to, sort of operate on short-term CRs through a lot of 2023. And so we have to sort of see how that ends up playing out. That being said, it's looking potentially, like Senate Democrats, may issue their own omnibus bill if negotiations do indeed end up falling apart. But that is very unlikely to pass the Senate. So assuming they do so and their omnibus offer fails, there's a chance that they may offer a full CR. But I don't know how much appetite there will be for Republicans to support a full year CR. I think, cuts in defense will be something that they're eyeing pretty closely. So all that to say, there is quite a bit of uncertainty right now. This is sort of the rodeo that we find ourselves in the end of every other December, and this year is certainly no exception. Just to touch on public health emergency, as mentioned already, it appears that that's going to go into early next year. We are hearing some chatter about maybe even June. But right now it looks like the Congressional Budget Office is scoring bills and using July 1st as an end date. So, there's still some uncertainty there, but I certainly at least the first part of next year, we should still be under this PHE. I was asked to touch on just a couple of exchange issues as well at a pretty high level. So first, on November 30th, CMS did release an RFI that essentially kickstarts a statutorily required review of the Essential Health Benefits Framework. So the RFI is looking for comments on the ACA's EHB package, like how benefits are described, whether a typical employer benefit has changed recently, and whether the drug classification is used to fulfill the prescription drug requirements, whether those should be updated. So as I mentioned, that was November 30th, and comments are due within 60 days. So we're looking at the end of January there. There has also been a recent push by some folks advocating to get HHS to address some high out-of-pocket costs by forcing insurers that are selling marketplace coverage to a little more strictly adhere to the ACA's rate setting requirements. It seems that over the years, some insurers have sort of strayed from that a little bit and have been underpricing some silver tier plans and overpricing the more generous gold level products. And so some states are taking some actions to address, this at their level, but this current push is largely for HHS to step in and fix some of the misalignments in the risk adjustment program. So that concludes my update. It's just a particularly hectic time of year, trying to keep the government funded and see what kind of package we end up with in the next couple of weeks.
Thank you, Gina. That was great. Do you have any does anyone have any questions for Gina? Well, maybe I'll ask you, Gina, are you in Washington, D.C.?
So today I'm coming to you from right outside of Boise, Idaho.
Okay.
And, yes, my work is all in DC.
Yeah, I was just wondering what the mood's like there. It seems like it's, in the scheme of things, you mentioned just the outcome was maybe not what people expected. Is it not as disruptive as maybe it could be, or what would you say?
Well, the mood overall is not great. Just with sort of end of year stress. A lot of, these sort of funding and appropriations, CR, all these kinds of conversations are largely taking place in a pretty tight circle at the leadership level. And so I think staff is frustrated and members are frustrated. I don't think anybody is terribly surprised as far as the election results go. Other than just the House flipping was not the flip that a lot of locals in DC expected. They thought it would be a much bigger swing. And I think having, 3 months ago, even there was still some conversation about, well, that Senate could still flip. So for Democrats to pick up a seat in the Senate, I think that did catch a lot of people by surprise. you know, depending on what happens with the House Speaker post, we'll see what we're into, and as far as working relationships go, next year. But I think 2023 might be a pretty active and wild ride for us.
And then just one other quick question. You mentioned HHS and they're maybe looking at how insurers are setting the metallic tiers. When would that go into effect? Would that be for 2024 rate setting? If that were to,
I believe for 2024, I will check on that to make sure. Right now, it looks like they're sort of in infantile stages and are just trying to review. So I'll check on that, and either I or Stephanie will get in touch with you on that.
okay, thank you.
All right, thank you all. You have a good day.
Good. Well, next we are going to talk about the Oregon Health Authority's legislative concepts. Hopefully our guests are here from the Oregon Health Authority Government Relations. And if you don't mind introducing yourselves and going into this part of the presentation.
Great. Yeah, I just got here. Unfortunately, you're stuck with me today. I'm Matthew Green. I'm part of the government relations team. The rest of the team is over in the Capitol building right now. It's legislative committee days. So I think there's a Senate healthcare is going on as we speak. So we're a little distracted, but I stepped away to talk about this, and I have a presentation to share. Oh, it's up there. And excuse me. This is a kind of a pretty, basically a quick list of all of the legislative concepts and the POPs, the policy option packages, which is i.e. the budget requests that we're putting forward for this session. My thought, how we usually do this, is to run through them very, very quickly and stop me if you have questions. I think there's a couple that you might be more interested in than others, but let me know at any point if you want to stop and focus on something for a minute. So this here is the entire team. You can see, well, I'm on there about halfway down, Matthew Green. We have a new interim director coming in, Ashley Thirstrup, who's been a manager in our public health division, been around the agency for quite a while. So we are going to go into a little bit of transition too, as are a lot of people, and with Ashley coming in as our interim director. I might also note, if you don't know him yet, Philip Schmidt, who's listed toward the bottom, who works on health policy and analytic issues and Medicaid issues, and in particular is involved with the health insurance platform bill that I'll mention in a few minutes. So if you don't know him yet and you're interested in that topic, he's going to be a good contact for you. And I always want to say that it's a fairly large team, and these are all our subject areas, but contact any one of us if you have a question or anything that's going on. We are all available for conversation, and if we don't know the answer, we can get you to the right person. All right, so the next slide. So real quick, if you don't know, we are the kind of the arm of OHA that goes and talks to legislators quite a bit, or helps executive leadership talk to legislators. And our role actually starts before, when we're working on helping staff across the agency work on legislative ideas and prepare them, and after session, where we're working on helping the rest of the agency implement the bills that have passed, all with the goal of advancing the larger goals of OHA, of eliminating health equities, of the triple aim, better health, better care, lower costs. All right, next slide. And these are some of the big themes that you'll see through the proposals that we have for this year. Health equity, the first bullet there, is the one that we really started with before we started preparing legislative ideas. The others kind of emerged out of the ideas that came up from us and that we had heard from community members from we tried to get into a lot of previous community outreach efforts and what had people been saying and how can we translate that into legislative issues. It wasn't perfectly done. I think we can do better next time, but that was definitely an attempt. So now we jump into some of the specific legislative concepts. The next slide. A couple about health equity. This first one is about data, about race, ethnicity, language, and disability, or REAL-D data, sexual orientation, gender identity, SOGI, shorthand. And there's been some advances in the last couple of years about making sure that we collect this data better, but not all of it is confidential under state law. Some of it's public records because it's not considered health data in the same way that the HIPAA rules apply. So this would add some confidentiality protections. And one that you might be interested as members of the advisory committee is a bill that's aimed at increasing and improving the opportunities for diverse participation and representation on committees, including by allowing for compensation in some cases, I don't think this applies to yours specifically, but in some cases where, at least for some of the members, compensation is not currently possible, and also kind of broader authority to OHA to take steps to look at ideas to how to increase outreach and other ideas, kind of get creative, gives us some authority to get creative about how we increase diversity. Next slide. Some big public health items. This first one's about flu vaccinations. Currently, pharmacists can give vaccinations for children 7 years of age and up, and as well as to the parents. But if they have a child who's younger than 7, then they have to make a whole separate trip to a clinic to get that child vaccinated for the flu. And so we're trying to reduce that so that more people it's more convenient for them to get vaccinated. A ban on flavored tobacco and synthetic nicotine products, which is exactly what it sounds like, banning the fruit flavors, the candy flavors, including menthol in cigarettes and all the various attractive flavors in vaping products that are largely responsible for getting a lot of young people addicted to nicotine. A dental pilot project program. The program actually promotes pilot projects that help advance oral health care in the state, kind of innovative things, especially for communities that are not currently well served. For some reason, the program itself has a sunset clause in it, so we're just trying to make it permanent so it can continue to do some good work. And a death with dignity fix. This is the Death with Dignity Act. In a lawsuit recently, a judge found that it was unconstitutional. The current residency requirement, the patient has to be an Oregon resident, was unconstitutional, so we're proposing to change that. The physician involved still has to be licensed in Oregon under the Death with Dignity Act. All right, next slide. One that I suspect you're interested in, and we can talk a little bit more about it now, and also I want to bring Chiki into this conversation, is the state-based marketplace, LC 471, which is, on the surface, exactly what it sounds like, is to transition from the current federal-based marketplace that Oregon is part of, and create a state-based one for a whole variety of reasons, including better access to the data, better ability to have things like special open enrollment periods and various other things. Chiki, do you want to jump in and add some to that?
Thank you, Matthew. So that was a fantastic elevator speech. That was actually a perfect amount of information for why we want to transition. So as we all know, right, the Health Insurance Marketplace Advisory Committee has recommended this since 2019, formally recommended this since 2019. And we now have a legislative concept that we've put forward. It's 471. So this is definitely going to be something of interest to everybody. So aside from real-time access to data, improved customer service. Improve customer service for Oregonians, for insurance carriers, for the state, flexibility to truly be responsive to the community as we would like to be. So that's my elevator speech to add on to Matthew's elevator speech. I know you might have some more questions. Again, as Matthew said, we can address them now, or we can talk about it a little bit more later as he goes through the rest of the list. So let us know your preference.
And I mentioned Phil earlier. He's the government relations person who's leading on this legislative concept. So he's the best person to ask if we don't have an answer. And I see Andrew has his hand up.
Thanks. My question might be a little premature, but is the expectation that the state-based marketplace would have fees that are lower or greater than the current exchange fee?
Our initial projection is that the overall cost would be lower.
That was a very enthusiastic thumbs up, Drew. So we will take that as support. That's the goal.
I think they said roughly 10 million, total cost 10 million a year instead of 20 million. And partly because honestly, now the technology is better and we can basically buy an off-the-shelf program to do this. It's not building something, artisanal from scratch in EIT terms. There's programs out there that do this.
You know,
So
since we,
Go ahead, Craig.
oh, thanks. Yeah, since we paused on this one and is so important to the work we do, maybe you can talk through the process that this will follow. You mentioned legislative days today, so I think that gets, what is that, to get the legislators familiarized with these concepts, and then are they more formally put into bills that are sponsored, and then they wind their way through? Can you kind of talk through
Sure.
what we're going to be watching?
So yeah, so legislative days right now is an opportunity for them to focus on some issues. I'm not sure this one is getting a lot of attention at legislative days, but it's kind of good for them to start getting organized and tee up some big issues. We have proposed these legislative concepts to the governor, and the current governor, Governor Brown, has approved them to advance. Of course, on January 9th, we'll have a new governor. So we do not yet have we do not have any indication one way or the other about the governor's views on any of these bills. We just don't have that information. What officially happens is the governor puts them forward to the legislature as her requests on behalf of the agency. This is true for all state agencies. And then it becomes a bill introduced, and it gets a whole different number. It won't be 471 anymore. It'll be like House Bill 2005 or whatever it is, and goes to committee. And then like every other bill, it goes through the legislative process where it has to be heard in committee in the House, and then voted on the House floor, and then in the Senate and passed on the Senate floor, or sometimes the reverse. You might go to the Senate first if it's a Senate bill. And public hearings in committee, opportunities for amending the bill, and ultimately assuming both chambers of the legislature pass it, then on to the governor for to be signed. And presumably, if it's a governor's request bill, it will, unless it changes dramatically, it would end up signing, although she has the opportunity to veto it. So it will be, a part of that conversation. I'm not sure if it'll go to one of the healthcare committees. It probably would. Because it's a large IT project, sometimes they get shuffled to one of the other committees, but probably to one of the Health or House or Senate healthcare committees. It would be on their docket to take up first. And we'll certainly be there. Excuse me. I had a cold like 3 weeks ago and it's still there. We'll be providing information to legislators, and anybody else outside of OHA is of course free to go down there and express their opinion one way or the other on it.
Great, thank you, Matthew.
Sure. The others, the Medicaid waiver implementation, you probably know about the waiver that we just completed the negotiations with the federal folks. And so this includes a variety of things. It was a placeholder, and actually probably should update this. It's getting fleshed out more with the details of what is actually in the waiver, but it's to implement that. And then the redeterminations bill, this is a follow-up, as you may be familiar with the fact that, once the public health emergency ends, which we're all projecting at this point is in March, then we have to start the process of redetermining people's eligibility for Medicaid. And this is a follow-up. This really is a placeholder in case there's any legislative issues we need around that, although at the moment we don't expect any. Next slide. And a couple of behavioral health ones. Payer parity, this relates to the 988 crisis call system. And there's a problem that's been noticed in other states where private insurers aren't covering the cost of when their clients call the system and receive behavioral health services, crisis services. And so that's a huge financial impact on the system. So require that they would pay for their customers. And aid and assist, this relates to the Oregon State Hospital. And there's been a federal court order about the rules for admissions and discharges in order to frankly get more people through the hospital faster and limit some of the lengths of stay. And so this is to implement that. Next slide. This is the whole giant list. And I'm not expecting to read all of these, but I'm about to paste into the chat the website where you can find them all. It's our government relations website on the OHA page. You can find all of these. You can read them, including 471. You can read some background explanatory information and so forth. So if you now or later have any questions about any of these, you can let us know. Next slide. And so we're going to jump into the budget side of it, POP, as I mentioned, this is policy option packages, which is a complicated way of saying a request for things that are not currently in our budget. The first one there is about funding to implement a lot of the ideas that have been talked about recently about health equity and build infrastructures, mostly within the agency, to build the infrastructure we need to advance health equity across all of the divisions. There's one about the Realty and SOGI data. As I mentioned, there's been a couple of bills requiring data collection. So a lot of this is technical assistance to healthcare providers and others about how to do it and help set up some of the systems and make it implemented. One about regional health equity coalitions. This is very popular groups within the counties where they exist currently, and this is to expand them more across the state. Next slide. Some public health ones. Public health modernization you may be familiar with. This is changing our both the state and the local public health system. So it's to get away from the tradition of the disease of the week kind of funding. We usually have been receiving for years. The tradition was the federal government would give us funds to fight tuberculosis or to fight AIDS or to fight something else. All good things, but we ended up with 100 different projects that are separated. This is to build the basic strength and infrastructure of local governments, local health departments in particular, to do kind of things broadly across different kinds of diseases, across situations, to both surveillance and response and education and different things. And a lot of the lessons learned through COVID are expressed here in this funding. Healthier Together Oregon, which is a state health improvement plan to help implement that. Another follow-up, frankly, from COVID about a stockpile of medical equipment and personal protective equipment to build that. We have authority now to make a stockpile, but we don't have the money to stockpile. And one on domestic well safety, which if you're in the countryside and you're on a well that is not hooked up to a water system, this is probably important to you. Next slide. A couple big ones related to Medicaid. The waiver, we're getting actually closer to an actual number on this one. And if you look on the website that I just posted a little while ago, you'll see an actual number, but frankly, because that number was written before the waiver was complete, so it was an estimate. So we're focusing on this is to make that happen. There is some state investment involved. It will leverage over $1 billion. We're estimating about $1.5 billion in federal funds in the process. So we think it's a pretty good investment, but there is some state added investment to it. And then the redeterminations, excuse me, and basic health program. To calling back to the legislative concept I mentioned a minute ago about redeterminations for people about whether they're still Medicaid eligible. This is to set up a system so that for those who are no longer eligible for Medicaid, a basic health program that they can be invested in. This is designed to ultimately serve everyone from 138% of federal poverty level, which is the current cutoff for Medicaid, up to 200%. And the aim is it would be seamless with the Medicaid system, which is part of this pulls in the health insurance marketplace issues and the system there to blend them to people who are maybe on Medicaid, make a little bit more money, go off Medicaid, and then make a little bit less money and come back, and they're transitioning back and forth to make it work, to both administratively make it easier for the agency, make it seamless for them, and most importantly, avoid loss of coverage as they make those transitions. So next slide. The first one here is about the 988 system again, and this is, as
Hey,
I
Matthew.
mentioned, yeah.
I'm here if you wanted to rest your voice.
Okay. Another one of our members, sorry, Colleen, who works on behavioral health issues, so she can jump in. Colleen Benson is another member of our government relations team, was also able to get out of the legislative days conversation. But so yeah, Colleen, if you want to talk about these for a minute.
Sure. So like Matthew said, the first one there you see is the 988. And this dollar amount that you're seeing is to kind of fund the 988 system. So the legislature requested the state perform an analysis and use a third-party contractor. And so this POP is derived from that analysis, and it was shared with the legislature. And then the second one there is the hospital staffing plan. So HB 5024 requires the state hospital to meet with unions and other partners to come up with a sustainable staffing plan. That staffing plan was submitted to the legislature last year and it was partially funded. So this is the remaining balance that you see. Back to Matthew.
All right, thanks. Next slide. And like the earlier slide about all the LCs, this is all of the budget requests. Actually, it's not all of the budget requests, this is half of the budget requests. We just highlighted some of the biggest ones, both in number and what we think are the biggest policy changes. There's a lot of smaller things in here. Again, you don't have to memorize them. These are listed. There's more information on our website if you want to follow up. If you want to go to the next slide, there's more on there. You can glance through them. And you have a copy of these slides now, so you can look through them at your leisure a little bit more. Note that the numbers here are general funds. So it's money coming out of the state general fund. A lot of these also have money coming from other sources, either dedicated account or federal in the case of Medicaid and a lot of other things, honestly. And so there's a few items on here that have no dollar amounts listed. That's because all the money is coming from some other source. But general fund is the one that's kind of the most critical and the hardest to debate around. So it's the one that we focus on the most. That's why we highlight it here. And next slide. So again, that's our website. It has information about all the legislative concepts, about the POPs, about the government relations team itself. There's contact information, and actually I have to put up contact information for Ashley and one of the new member. That's going up shortly, but it has information, contact, and bio of all the government relations members. So that is our presentation. We're happy to take any questions you have.
Thank you, Matthew and Colleen. Yeah, do people have any questions about any of the specific legislative concepts or the budget requests that we walked through?
Yeah, Andrew.
Andrew.
Craig, this might actually be a question directed to Craig. Will we have time today to discuss, I guess, some of the concepts with respect to funding the basic health plan related? I don't think it necessarily comes from a budget request, but my understanding was that some dollars might be moving from the individual exchange to the basic health plan coming out of reinsurance. And I just wanted to make sure, although I bring it up now because it's tangentially related to what was just presented, I wanted to make sure we had time today to discuss that.
Yeah, that's a good point, Andrew. I think that came up. I'm not attending the Bridge Plan Task Force meetings, but I did hear there was something about that particular issue that was discussed. So I think that might be best saved for the program update that we'll have later in the agenda. And that's maybe to alert Lindsay or somebody else to think about that as they walk through that presentation.
And I know just enough about it to be dangerous. I'm not going to get into it in depth right now. I will offer up Phil, I'll volunteer him, to come to a future meeting and talk about it in more depth. And he might be able to bring somebody who's been working on the bridge plan to talk more about it as well.
It's like Paul has a question.
Sure, and it may be an impossible question, but like, is there a rule of thumb for how much of this could actually happen? Like, is it, hey, yeah, most of this gets through, half of it gets through? It really just depends every single year.
Yeah, the answer is it depends. Okay. The legislature didn't change that much. There were some predictions that it might change dramatically and the governor's office might change dramatically. That's not to say it hasn't changed. There's a different set of legislators than there were 2 years ago or last 2 sessions. And excuse me. So in the big picture, about 10% of all bills pass. Probably OHA and state agencies in general, because the governor is involved, probably have a higher percentage than that. But and sometimes it's hard to predict which ones will end up. It certainly depends on which ones both community members respond to the most and end up talking to the legislators about, ones that kind of resonate most with a particular legislator who takes a lead on it, which ones the governor's office decides to prioritize. And reality is they have to prioritize. They can't try to pass every single bill. There just isn't, there's never 100% on any of these. On the budget side, there are going to be some budget challenges. They're not as bad as some people might feared with a big recession, and the revenue forecast has actually been pretty good. But the waiver, Medicaid waiver request is fairly large, and there is a hole in some of the current Medicaid funding to get up to the current service level to just provide the services that we currently do now. There's a bit of a hole that needs to be filled. That has been successfully. There's been larger holes in previous years, I'll put it that way, that have been filled. Because it's an important thing to the legislature, has been in the past. But yeah, there's always competition for funding, and certainly not everything here will be funded. But can't give a real accurate guess of how much.
Matthew, if I may add, so also part of the odd session, the longer legislative sessions, is also the agency budget bills. So wanted to flag for you all that that's also the time of the biennium where we come to the legislature and put forward our proposal of how much we will need for the upcoming biennium. So I think, especially since we have a whole lot of new members this year, how can the Health Insurance Marketplace Advisory Committee be involved in the past? And we would welcome you, of course, to be as involved as you would like to be. The committee members provide either support or non-support through written or verbal comments, depending on the bill. So if you would like to provide information or comments for our upcoming LC 471, however that bill will be, and then of course our budget bill, we will always welcome your feedback somehow, your formal feedback to the legislature somehow, some way. So I just wanted to flag that for you all, that there are opportunities for engagement. There are opportunities for engagement with the legislature through their formal process. And then we will also bring forward potentially updates through the next, through the 2023 Health Insurance Marketplace Advisory Committee meetings during session as well. So this is not the first and last time. As Matthew said, he volunteers Phil. I also volunteer Phil, but I also volunteer my team, and we're always here for if you have any information you'd like to learn more about, or if you want to hear more about for whatever what's going on, we'd be happy to come back at any time.
Thanks for adding that, Chicky. I remember that process on having the opportunity to support the budget in front of a legislative committee. So it's a good experience, and I think it does help.
Every now and then there's a request from legislators that committee, chairs usually have testified in the past. I've seen that happen. That doesn't always happen, but I've seen it.
And sorry, I keep adding one more thing. And of course, this is going to be the first time we're doing this under OHA's banner, officially, fully under OHA's banner. So last year, 2021, Senate Bill 65 moved us over. There was a little bit of interaction, but this time we're fully in OHA. So we are also, of course, adjusting to the process, and we would, of course, be lockstep with government relations, making sure that we follow the right process and we bring everybody along for the ride. It's going to be a fun ride. It looks good. It's going to be a fun ride, and looking forward for you all to be part of that.
All right, if there's no more other questions, then I'll let you go, and we got other stuff to do, but please do feel free. Oh, was there a question?
I did. Craig does have one, looks like.
I'm not going to let you off the hook.
Okay.
Just maybe a couple other quick questions. I noticed on the budget request, there is a placeholder for the new technology, moving the marketplace.
Yeah.
But it looks like there's not a dollar assigned yet. So is that just in process?
Yeah, I think that's in progress, and Phil can probably give you a better update, and maybe even he has some information on where that is before your next meeting. If you want to email him.
Actually, so the legislative concept that the transition to the SBM, it's a large project, and it will be two large phases. So for what we're going forward in 2023 is the approval to move forward. And once and if we get approved to move to our SBM state-based marketplace, then we will launch our RFP, a request for proposal. That's why there's not a large dollar bill that you will see most likely, because we really don't know. We won't know how much we will need until we put forward a request for proposals, until the vendors give forward their price tags, and we go through that due diligence and through that whole process for the very legal procurement. So all that to say, once we have that number, then we'll go back and then give that price tag and then get the approval to move forward. So all that to say, LC 471, state-based marketplace transition, is for open enrollment 2027. So yes, we know it's only 2023. It's a long process because we would like to be thoughtful and methodical and make sure we do this right. We do this right. We do this well. We engage with community. We engage with carriers. We engage with other state agencies. So again, just wanted to flag that this is for open enrollment 2027. So November 1st, 2026, if all goes well, including the approval through the 2023 session. So backing that up, it is a long runway, and that is intentionally so.
Thanks, Jackie.
And I'd put a twist on that too, that it gives us the opportunity for a long runway and which creates the opportunity to talk to community members, to talk to people around the state who are involved, as opposed to the current system where we kind of take whatever we get. You know, we follow. We don't have the opportunity to really talk to people and make changes to the current system.
Great, that's helpful. And then the last thing for Matthew and Colleen is when you pull these legislative concepts together, what's your process to determine which ones you're going to move forward?
Ultimately, short answer is the agency leadership decides. Now, they decide which ones go forward to the governor's office, at least, and then the governor's office, and ultimately the new governor decide from there. There's a lot of back and forth with divisions. Divisions were invited to propose things. As I mentioned, they were strongly encouraged, and in most cases did look at previous things that they've heard from community about. Sometimes it wasn't necessarily about proposing a specific bill, but it was about a need that had been expressed by communities through previous, the State Health Improvement Plan or Medicaid 2.0 or CCO 2.0, and different things like that, where there had been a community feedback, citizen participation element to it, and so we had some information, tried to use those as much as possible. And then they kind of bubbled up, and ultimately the agency leadership up to Patrick Allen had to make some calls, and not everything got through. This is not the full list of proposals that were made. There were some that were dropped in the process, and some POPs that were dropped in the process. So that if you want to think about how many end up passing, well, yeah, some of them have already been cut, honestly. We do this every 2 years, this process in some form, and we are working to make it a process where it was very intentionally, we're aiming at better community involvement in that process. Like I said, we did some of it this year. We did not do as well as we would have liked to have done. And ultimately, it would be ideal to talk to representatives of interested and concerned communities all across the state in advance to develop the ideas and then turn them into LCs. We're trying to get away from what has traditionally happened, where, frankly, we kind of in an insular way, OHA writes their proposals, and then the last second goes out to various interest groups and says, "You okay with this?" We're trying to reverse that process as much as we can. We got a little bit of the way there this round, and we hope to get much further in that way the next round, which will be in 2025, and the process for that will start in 2024, early 2024. It's a long cycle. It's almost never over.
Thank you. I appreciate that insight. I think that's it then.
Yeah.
Thank you both for your time this morning.
Sure. Feel free to contact us either directly or through Chiki, and we're happy to come back. And I'm sure Phil's happy to come back and talk to you anytime.
Okay.
All right. Thanks.
Thank you. Next up, we're going to talk about the Medicaid migration to the Marketplace project, and we're going to hear from the Marketplace team.
Hello, everyone. Hopefully you can hear me. My name is Amy Coven. I'm the stakeholder and communications analyst here at the Marketplace. And so just to kind of jumpstart the conversation about this project, we just wanted to give you an idea of where the project fits into the grand scheme of things. So we put together this map to show, this process map to show a consumer's journey into getting health coverage either through Medicaid or through the Marketplace. I'm not going to go through it in great detail, but we do see that there are multiple points where we reach out to the client, letting them know if more information is needed, what their eligibility results are, and so on. And so, Dawn, next slide, please. This particular project, the Medicaid Migration to the Marketplace project, which is part of the Public Health Emergency Unwinding, really fits in to the part that you see here on the screen, where when somebody receives a notice that says that they're no longer eligible for the Oregon Health Plan, this project will kind of jump in to mitigate the risk of folks losing coverage altogether. We want to make sure that folks are understanding what their options are. We're going to try and reach out to folks and however is best for them. So multiple different avenues of communication, letters, text messages, phone calls, and depending on where they're at in the process and how long it's been since they have received their notice that they're going to lose OHP. We will have a call center that we're going to be standing up that's going to be dedicated to helping folks transition from OHP to Marketplace coverage and understanding what their options are, and even connecting them to local resources like assisters and insurance agents and brokers. And we're going to be working in really close coordination with community partners and insurance agents and brokers to help folks transition as well. We know that the process is really confusing and daunting in normal times, and I think that we can all recognize that this is going to be amplified with so many people going through the process all at once. So with that, I'm going to hand it over to Miranda so that she can talk a little bit more about how community partners will be fitting in. Next slide.
Good morning. My name is Miranda Amstead, and I'm the Community Partner Liaison. And I will get going on my section here. So we anticipate that over 300,000 Oregonians will have their Medicaid eligibility redetermined. Due to House Bill 4035, we were awarded funds to expand our partner network into Oregon's communities that are at a higher risk of being harmed by healthcare inequities so that we can ensure that these communities get the information they need to continue access to affordable healthcare, maintain their continuity of care, and know their health coverage options with the Public Health Emergency Unwinding. The Medicaid, the Marketplace Migration Community Partner Program will result in more Oregonians having access to information on their health coverage options and access to affordable health coverage with the help of our trusted coverage experts. We just have a really robust, wonderful group of community partners. Many of our partners are trusted members of communities that are experiencing disproportionate impact and are at a higher risk for being harmed by healthcare inequities and are most affected by social inequities. Next slide, Dawn. Many Oregonians moving from Medicaid to the Marketplace plan may not have access to information they need to help them know or know how to utilize their plan or navigate their health coverage. So having access to organizations with trusted community members that can help assist with post-enrollment literacy is going to be key in maintaining the continuity of care during this transition. The Medicaid to Marketplace grant funds are going to support an increase of Marketplace outreach and enrollment assistance for communities put at a higher risk of being harmed by health inequities. So the budget allocated under House Bill 4035 is $2.5 million. And of this, $2 million is going to be allocated to the Community Partner Program, and $500,000 is going to be allocated to the partner insurance agents. So we plan to make these funds available to all of our current partners to support the redetermination process during the Public Health Emergency Unwinding. And we plan to also utilize these funds to bring on some new additional partners to address service gaps in communities of our focus, most harmed by healthcare inequities and most affected by social inequities. The new partnerships established will help us increase our service to equity by helping us expand our reach into communities of focus with service gaps by providing enrollment assistance, coverage option counseling, and then post-enrollment literacy support during the public health emergency unwinding. And that's all from my slides.
Thank you,
I believe
Miranda.
back to Amy.
Thank you. Yeah, I'm happy to jump back in. So when talking about the overarching public health emergency unwinding strategy, the communications aspect of it, we're really taking a 3-phase approach. So we're currently in phase 1, which is the pre-PHE ending phase. And what that entails is really encouraging folks to update their contact information so that we make sure that we are reaching people once those redeterminations actually happen. We want to avoid people losing benefits because they didn't get notification or they fail to respond. So that's where we're at right now. You'll see TBD marks for the phase 2 and phase 3 for the very obvious reason that we're yet to know when the PHE is actually ending. But once we get that 60-day notice that the PHE is going to end, we will shift to phase 2. And under phase 2, the goals are to really let the public and really anybody know what to expect and how to prepare for the end of the PHE. And then again, to reinforce that folks really need to keep their information up to date. And then the final phase, which is phase 3, is when we will actually enter that renewal period. So once the PHE ends, we're going to really focus on encouraging people to read all of their notices from the Oregon Health Plan and from the marketplace and all of the entities, DHS included, that will be sending notices. And then just making sure that folks understand how to continue to stay covered or to keep services that they may be losing or replace those services. So there's a really close coordination when it comes to communication between our team and the OHP team. We're wanting to make sure that messaging is very succinct and in line with each other. And we're working very diligently at that and meeting frequently to adjust messages as necessary. Next slide. So the next few slides just kind of talk about some of the different communications pathways. I'm not going to read these in full because it's a lot of information, but wanted to make you all aware of the different pathways that we have identified to communicate with some of the core audiences. So this first one is to reach out to public members or former OHP members. We intend to use email through newsletters, through GovDelivery, email and postal mail, use our website, social media, text messages, which are contingent on opt-in, and then networking meetings. So our outreach team is going to continue to attend the various meetings that they do, and we'll incorporate these communications in their messaging when they're out in the field. Next slide. We intend to communicate very thoroughly with community partners and agents and brokers to make sure that everyone knows exactly what's happening, what to expect, and that they're fully prepared. This will include the check-ins that we have with our grantees, training, which we typically do annually. However, we're currently evaluating any opportunities for training regarding this project. The monthly collaborative meetings that we have, emails, newsletters, updates, and so on. So we do plan to communicate as frequently as possible and make all tools and resources available to all of the folks that are doing the great work for us, boots on the ground, so that they can serve their clients. Next slide. And then for external partners, we plan to use a lot of the same tactics. These are a lot of community-based organizations that maybe don't do, specifically healthcare or health insurance, but might touch folks who, might have touch points, I should say, with folks who need help and aren't aware of what's happening. So we already do a lot of this work, so we will just be bolstering that, the messaging with the 3M. And Drew, I see your hand. I'm happy to take your question.
Thank you. I know a lot of providers also facilitate enrollment in and out of Medicaid and onto other. Is there outreach to plan for large provider groups or any provider groups?
That's a great question. So one thing that I didn't mention before that I should have, so I apologize, is that a lot of our communication strategies for the marketplace side of things is kind of piggybacking off of what the OHP teams and the DHS teams are doing, because the foundation of this work is really rooted in those programs. So we are kind of taking the back seat to what they're planning to do and letting them kind of take the lead. And then we're filling in with the transition, messaging. And that does, it's not to say that we're not doing that messaging, but what we're doing is mostly making sure that the messaging that they're doing is including all of the pertinent details about transitioning to the marketplace so that we can hopefully send one message and get all of the information out rather than sending a bunch of disjointed and fragmented messages, as quite honestly, we've kind of done in the past. So I know that this list is specifically for the marketplace side of things and how we plan to directly communicate with folks. But there's a much larger version of how OHA, or I should say the OHP teams and the ODHS teams plans to communicate with different folks, and provider networks are definitely included in that. And then I think I have one more slide, which is for our insurers. So of course, we want to make sure that insurers are abreast of everything that's happening, especially as there is very likely going to be a large influx of people transitioning onto private plans mid-year, which is quite abnormal, I know, for what we normally see throughout the year. So we do plan to keep folks in the loop as far as what's going on and gathering feedback whenever possible. Of course, this particular meeting is one avenue to do so. We've had the Marketplace Community Conversations meetings in the past, which were great, and we plan to do that again if or when the need arises, and then the industry communications meetings as well. And I think that's actually my last slide, so I'm happy to answer any other questions that you all might have. One thing I might actually add just really quick that I didn't say before. So as I mentioned, we are letting the OHA and the ODHS teams take the lead on, I keep saying OHA, I mean OHP because we're part of OHA now. We're letting them kind of take the lead. So they are doing a very large marketing campaign. They're planning to do some stuff for this whole redeterminations process and everything. And so we are not currently planning a marketing campaign. We're always nimble. So if something changes, I'm sure I can get leadership approval to do something if we need to. But I think the majority of marketing will definitely come from that side. And I saw you raised your hand too.
Yeah, good morning, Amy and Miranda. I'm just asking, as a broker, is there any possibility to have a software program that as a broker can come in by type their name or their social security to check their organ health plan eligibility? Because, we're working into the cultural market. They claim they don't receive text, email, or mails, and they don't remember logging into the OHP account or have an account. How can we help? Thanks.
That's a fantastic question. And I think that, as an agent and broker, and our sisters as well, that we really see you as a valuable resource to help connect folks, especially those harder to reach communities around the state. So I would venture to guess that the easiest way to get that information would be likely through the One system. And I think there's been, that's outside of our purview a little bit, but I do believe there's been some agents that have gotten access to that for their clients. So it might be something where we would want to connect you with the CPOP team, the Community Partner Outreach Program, to see if we could get you access to that system. That would be my first instinctual answer, but I would definitely defer to any of the other Marketplace team members if they have a different response or anything to add.
This is Lindsay. To Om's question, what has worked best for has worked, like previously worked best for me, was instead of going through one, was when we have connections with people who had access to MMIS, and that gives assisters and agents way more access to know current active OHP status. It doesn't give any information about, if someone's coverage is going to end the following day, but during the past 2 years that hasn't really mattered. However, MMIS has been a lot more accurate, a lot more helpful in being able to check one, since if you're not associated with that particular community member, then you can't find them, or you have to start an application process to see if it gets pended to see if they come up or not. So that would be my suggestion, is find someone who has access to MMIS.
Thank you.
Thank you, Lindsay.
So Amy, before you wrap up, if there are no other questions, or maybe if you're still thinking of some questions. So as we all know, or you've already probably heard, right, the current public health emergency is set to end January 11th, right? That's what's been communicated out loud across all the states. But we also know that the feds have promised the states that they will give us 60 days notice. So we did not get that 60-day notice in November. So we fully expect at least another 90-day extension. So we are hoping, hopefully in the next couple of weeks, we'll find out if it is a 90-day extension to April, or if it's going to be longer. We're hearing various directions depending on which grapevine we're listening into. So if it's a state grapevine or if it's a federal grapevine, we're hearing different directions. So please know that, yes, we will be coming to the HIMAC meetings, but also want to recognize Nashoba and Gladys, who have been part of the community partner work group. I believe they will continue to be meeting still in the next couple of months, talking about things like this, right? What do agents need? What does the community need? So we'll make sure, the team and I, we also attend those meetings, and we'll keep our ear, of course, to the ground. And if you have other feedback, please know that these are not your only opportunities. Please do reach out to myself, and we'll make sure that we flag your questions, we log your requests to see what we can and cannot do, right, as we start implementing our tactics for when the public health emergency is truly going to start being unwound.
Thanks, Chicky. Yeah, thank you, Amy and Miranda. This is really important work, and it's great to see how organized and thorough it is. I'm just curious, looks like we do have a question in the chat. So
Holly is asking, Holly's asking if there would be a mechanism for agents and brokers to use the CP consent form and secure email system to send the consent forms and be able to request status. That's a really great idea, and I am happy to take that. I don't know, Cable, maybe you would be better for that. I don't know. One of us on the team can take that back to the OHA side of things and see if there's something that might be able to be done. Thank you for that.
yeah, thank you, Holly. What I was going to say is, since we have great representations from agents and community partners, if there's just any other comments or feedback from people on the committee about what they've seen. Okay, well, I have a question then for you. Do you mind going back a couple slides, Dawn? Keep going. I'll tell you what, if you could stop there. So Amy, you mentioned, actually, there's perfect, that you've started the outreach on the pre-PHE ending. I'm curious about how that's going. Are you getting much response, or can you tell?
So a lot of the messaging, like I said, has come from the OHP and ODHS side of things. We have definitely amplified those messages in our newsletters, our updates, our monthly updates. Some of the things that have been done so far have been some partner webinars, which I actually just learned yesterday that they've been averaging about 200 participants per webinar, and I think there's been 3 or 4 of them so far. We're currently evaluating, what topics we should do going forward. And then the other thing that has been happening is there was a big campaign on the OHP side of things, dubbed the pink letter campaign, but they weren't really pink letters. They were just letters. And basically they went out to all members to do two things. First of all, to encourage folks to update their information if they got the letter, but also so that OHA and ODHS could track returned mail and figure out where the holes and the gaps were. I don't have the latest data, but I can tell you that the returned mail was a lot lower than what they anticipated. So we're hoping that that means that they actually got to people and that we're not just going to get a flood from the post office one day. But it seems like the messages are getting spread very far and wide. We're just one messenger. The CPOP team is doing a lot of messaging and various other groups. So I think it's going very well. But I don't have any data to support that. It's all anecdotal.
Yeah, no, I think the return mail is a good data source, and it's, I think, a reflection on starting early and making sure we are reaching people. I think that's helpful. And then Dawn, if you don't mind, can you go back 3 more slides? Just one more question I had. Yeah, to that one. So I think I just wasn't paying attention or that aware of the process, but I understand the market or OHP reaching out to people, but can you describe a little bit more what the federal health insurance marketplace is doing? Are they getting their own feed, and are they qualifying people for, can you maybe describe that a little bit more?
Well, as we all know, the kind of bummer answer is no, they're not pre-qualifying people or anything like that. But so in recent months, what we've been doing is when we've learned of people who apply for OHP and are no longer or are not eligible, maybe they're over income or eligible for CALM benefits, something like that. We have been sending notices to them, letting them know about potential marketplace eligibility. So that's actually been something we've been doing for a little bit to kind of get our feet wet so that we could get some practice for when the Medicaid Migration to the Marketplace project happens. We will be sending, from the state side of things, we will be sending letters to folks, letting them know about marketplace options, and we're still fine tuning those letters, but I think we'd be happy to share those with you once we have them ready and closer to final. And then the federal marketplace is also going to be sending a notice to folks when they are found no longer eligible for OHP as well. So there's going to be 3 notices that folks receive: the closure notice from OHP, and then the letter from us, and then the letter from the federal marketplace as well. And that's not including any emails or text messages or calls.
So if I also may add to that, so there's a new thing that CMS healthcare.gov is implementing this. Once the PHE emergency, the public health emergency unwinding will start, they're going to send what they're calling a 30-day notice. So they're going to take the account transfer file that states send to them. And anybody who has not signed up for a market, so we know, so for example, hey, John Smith, you are, your information was sent to healthcare.gov on March 30th, and your Oregon Health Plan will end on May 31st. You have 60 days to sign up for a marketplace plan. You could be eligible, please sign up for a marketplace plan. On April 30th, 30 days after they got the healthcare.gov gets that account transfer file, healthcare.gov will be sending a 30-day notice saying, hey, we noticed you haven't signed up for a marketplace plan. You have 30 days. So they will get that extra push. And what's really nice this year is we will get a list of who's in that 30-day notice list. So we in the marketplace here in Oregon will take those, we call them, they're still not converted, right? They still haven't signed up for a marketplace plan. They're warm prospects. What we're looking into is we're going to start calling these folks, calling and maybe texting. So we are still very much in the development process. So aside from letters, we want to make sure that they have an extra avenue that we can reach them. So we will be also calling and texting them at the same time, 30-day notice, roughly around the same time the 30-day notice letter from CMS goes out. So all to say, lots of notices, lots of ways to get the information, because we really want to make sure that Oregonians know If they're no longer eligible for the Oregon Health Plan, you have options, and we would like to be able to offer our help to get them converted to a Marketplace plan.
Thanks, Chicky. That's great. Well, I don't see any other questions for you, but thank you again, Amy and Miranda, for your presentation this morning. And that should bring us to our public comment and close to a break too. So I'll open things up for public comment now. Well, I don't see any or hear any, so I think we'll close that and we'll now move on to break. A little bit ahead of schedule. I think our break should end at 10:35. Probably could stick to that. Does that sound okay, Chicky?
That sounds great. So officially we are in break. As Craig said, please be back by 10:35. Thank you.
Thanks. Well, welcome back, everybody. Should be coming back from break now, and our next topic is on the bridge program and the marketplace mitigation updates. And we have joining us Tim, Katie, and Lindsay to present on that.
Good morning. Thank you for having me back. For the record, I'm Tim Sweeney in the Office of Health Policy at OHA, and we get to do another entertaining update on our work on the bridge program. And so this gonna kind of provide a handful of stuff. It's always good, I think, to just do a quick reminder of what it is that we're doing and the vision of the program, and then got some information on the actuarial analyses that have come back to the task force over the last couple months, and then some information on the preliminary final recommendations and sort of the next steps and what's happening over the course of the next year and beyond. So a quick refresher on the task force and the vision. So next slide. The task force, again, for folks, was charged with developing a bridge program that would provide affordable coverage and improve continuity of coverage, especially focused on folks who move on and off of the Oregon Health Plan, so on and off of Medicaid, due to sometimes relatively temporary income fluctuations. And so it's designed to improve coverage continuity and maintain the coverage gains that we've seen really over the last couple of years. Next slide. And it fits within the, one of the impetus for this is really related to the post-public health emergency redetermination period, which I know y'all have also heard lots about. And this bridge program is one of the places where we expect folks to get coverage when they're determined no longer to be eligible for the Oregon Health Plan. And in particular, this is for that 138 to 200% group, and it would provide another source of coverage in addition to employer coverage in the marketplace. Next slide. The vision of the program, and this is in House Bill 4035, is that adults in this income range would be able to stay in their CCOs, to stay in the plans that they're in when they're in the Oregon Health Plan. And so when their income goes up above 138, they would not have to switch plans. That this would have little or no cost for enrollees, no premiums or copays. It would cover a robust set of benefits that's based on what is covered in the Oregon Health Plan, that it would enable the CCOs to pay providers higher reimbursement rates than in the Oregon Health Plan, if possible, if financially possible, and that this vision down the road of potentially enabling consumers in this income range to choose between this basic health program and a subsidized coverage option on the marketplace. That is the vision as set forth by the bill that really kind of guided what the task force did in developing their recommendations. Next slide, please. And based on that vision, and one of the other pieces of the direction was for the task force to consider phasing possibilities, so it's not just rolling straight into a full-fledged basic health program. And so this sort of shows, without dates, because the public health emergency keeps getting extended, the current pathway towards a basic health program. And in phase one, which would be at the end of the public health emergency, Oregon is pursuing a Medicaid waiver that would expand income eligibility to keep people in this income range from 138 to 200% of poverty, to keep them on the Oregon Health Plan until we get to phase 2 or phase 3, until we get to the basic health program. Phase 2 would be to move, again, just these folks who are now covered by the Oregon Health Plan, and who will move into this new temporary eligibility category, to move them then into this basic health program, keeping them in their current CCOs, but then not moving folks who are currently covered by the marketplace. And then in phase 3, which is the full launch of the basic health program, all all adults 138 to 200% would be covered by the basic health program instead of Marketplace or instead of the Oregon Health Plan. And so there's still the same rules of with the tax credits now, that if you have affordable employer coverage, you wouldn't qualify for the BHP, but it would remove that population from the Marketplace into the basic health program. And then in the long run, phase 4, if policymakers, if the state again continues to go this direction, we could revisit and look at the idea of enabling choice between a BHP like product and Marketplace coverage. I see Craig's hand is up, so I'm happy to stop and take a question.
Yeah, sorry to interrupt you
No
in the
problem.
middle of this, but when I've seen this particular slide, it typically has the years attached to each of the phases. I see that they're not on here. Is that because they might be moving, or is that just?
It's in general, it is because the slide becomes out of date quickly every time the public health emergency extends. The general the working timeline at the moment would be phase 1 happens whenever the PHE ends. So let's say it happens in April of 2023. Phase 2, there is some flexibility as to when phase 2 could occur. At the moment, we're planning for that to be sometime in 2024. The longer we can go in phase 1, the more we're ready to implement phase 2, and the more we learn about this population of folks moving from the Oregon Health Plan. But there's not a firm date as to when phase 2 would happen. And at the moment, the working timeline for phase 3 would be January 1, 2025. Yeah. So yes, fall 2024 open enrollment for coverage beginning in 2025 for the full basic health program. And there's still the potential for moving timelines with all of this, but that is the sort of the soonest that's likely based on the current timelines. And one of the caveats with phase 4 is that enabling this choice definitely makes it a much more complicated program, and that's when direction from CMS is quite clear that healthcare.gov would not be able to support that. So the phase 4 would be predicated on the state eventually having a state having its own Marketplace platform when we want to revisit that phase. Okay, next slide. So over the last couple months, the task force has heard 2 big actuarial reports from the Oliver Wyman team and Manat, who we've been working with to examine this program. And I'm going to go with the most recent one, and then we'll spend some more time on I think what folks will care more about is the Marketplace impact. So we had Oliver Wyman and Manat, and we worked with our Medicaid actuaries, Mercer, to create an analysis of the potential cost to serve the BHP population, the cost of providing OHP-like coverage to this population, and then what would be our projected revenue from the federal government based on the basic health program formula. And at a high level, this analysis suggests that we could do this, that projected revenue narrowly exceed estimated program costs, and that this is the case for each of the 3 populations that we've been focusing on. And one is the folks who we expect to move from the Oregon Health Plan to a BHP. The second being folks who are currently covered on the Marketplace now and who would move to the BHP. And the third being approximately 10,000 or so folks who are currently uninsured who would be expected to enroll in the basic health program. And so for each of these 3 population subsets, the Mercer and Oliver Wyman analysis found that we would get enough federal revenue to cover the costs of serving these populations. That said, it is a heavily assumption-driven forecast. You know, we there's only so much we can do to figure out what it costs to deliver a OHP-like product, to deliver Medicaid benefits to a population that is not a Medicaid population, right? Those costs are built on the historic costs of delivering this service package to Medicaid, and this is a different population. And so there's some analysis that Mercer did to look at the folks to come up with a proxy population within the Oregon Health Plan of folks that we think are more likely to land in this 138 to 200% income level. And then that was connected to the population that they looked at of folks on the marketplace between 138 to 200% to come up with some estimates of what it costs to deliver this service package to this population. And so if we're off in some of those assumptions, if some of those estimates are off, that would have an impact on the resulting conclusions. And related to that, as part of the task force presentation, there were a handful of different scenarios that were run, that were looked at to sort of sensitivity test the conclusions. And it is positive in a sense of, with most of the high level scenarios, it wasn't like it went from having a narrow surplus or having revenue exceed cost to having it flipped, but it does make it more narrow depending on what actually happens. And so given this uncertainty, we're saying it's really important that we take the time in phase 1 to look at the population that's coming from the Oregon Health Plan and really have a better sense of, continue to learn and refine the costs and revenue estimates. So the next slide highlights some of the conclusions. So prior to that actuarial work, the actuaries did an analysis to estimate what the impact would be on the marketplace itself by removing the 138 to 200% population from the marketplace and into a basic health program. One of the charges in the bill is to consider the impact on the marketplace and to propose solutions to mitigate any negative impact. And so the first step is to sort of create an analysis of what is likely to happen. And on the whole, the conclusion is that enrollment remains relatively constant in this scenario. And the big takeaway is because the gains from the ARPA subsidy enhancement are much more significant than the losses of purchasing power, if you will, from the loss of silver loading. And so relative to pre-ARPA, the tax credits that people qualify for are still generally higher than they were, even considering the silver loading reduction. That said, premiums for unsubsidized purchasers decline because of the removal of silver loading and it's a slight improvement in the morbidity of the risk pool, whereas purchasing power for subsidized consumers, especially for those who are using their tax credits to buy gold or bronze plans, does decline a little bit. And so while the broad conclusion is that we don't see a major reduction in the number of people who are enrolled or a dramatic problem because of morbidity, there is some lost purchasing power because of the loss of silver loading. And the task force then started to discuss different ideas as to how we might come up with some strategies to keep people whole. So the next slide, I think, has a little bit more detail on what the conclusions were in terms of the movement of people across plans, given in the scenario where the BHP removes the under 200% and the subsequent changes to silver loading. And for the most part, we can see that there's some reductions in purchasing of subsidized gold plans, some movement towards the 73% CSR plans, but that on the whole, the total number of people in the individual market doesn't decline very much. And I think we might have alluded to some of these findings at our last meeting, but I also know that the last HIMAC meeting was like just a few days before these results were given to the task force. So some of this is probably new and new information. So I'll let this sit here for a second in case anybody has any questions. Yeah, Drew.
Do you have this similar table for the lives between 200 and 400% of the FPL? You'd mentioned earlier that there were some differences between unsubsidized and subsidized members, and so I was curious if this had been studied at in essence what would continue to be the subsidized level.
So I mean, this is everybody in the individual market above 200%. I would have to ask the actuarial folks if it's how easy it is for them to narrow this just to the 200 to 400. But we could certainly ask about that.
The reason I ask is because you did allude to the fact that the impact is on the lives that are remaining subsidized, that aren't going to be eligible for the basic health plan. I had a follow-up question, if that's all right, which is you mentioned that those subsidized members would have reduced purchasing power. Has that been, in essence, kind of monetized? Like, what does that mean for a subsidized person then? Even after subsidies, how much more will they have to either pay in premium or experience in out-of-pocket costs? Is that no?
So yes, to some extent, and this was there were some additional tables presented to the task force that go into more detail on this, and the short answer is it depends on income level and plan selection what that impact is, and the broad conclusions presented to the task force were especially for folks using their tax credit to purchase gold and silver plans, there is a modest increase in their premiums. That said, for folks who are still going to purchase the second lowest cost silver, their premium doesn't change, even if the amount of their tax credit does, because the underlying cost of the second lowest cost silver plan also goes down. So that is some of the, I think, what drives some of the movement into silver plans. But we could certainly share the slide deck that was presented to the task force that has some additional tables that show the, for a 45-year-old person at 250% of poverty, this is how the value of their tax credit changes, or how the value of their or the net cost to them of a gold or a bronze plan differ. I mean, I think one of the, if I can remember some of the takeaways, for older consumers, the impact is more focused on gold plans. They're because of the rating, they're still able to largely get bronze plans for $0 based on the value of their tax credit. For younger consumers, it was more evenly shown that the cost impact hit both the gold and the bronze.
But then obviously someone moving from gold to bronze is going to experience significantly more out-of-pocket costs.
Yes.
That, I think, is what I'm trying to get at, is what's the net impact to the remaining, to the simulated consumers, especially those that are losing purchasing power.
Yeah, I mean, I think, and maybe I would maybe phone a friend to Katie Button and see if she has any thoughts on this, having a little bit more connection to the plan side of this. I mean, I think it's really hard to show too much detail with that, because we don't know the decisions that are being made, and in some case somebody could save $1,000 a month in premiums by switching from gold to something else, and in theory, it raises their deductible by $2,000, but maybe they only spend $800 of that. So the actual impact on them is harder to model, because all we know is the plan that they're in, not the services that they use and what it actually costs them.
I would agree. I think, you know, we see mostly in gold plans that those are folks who have the more expensive needs anyway. And so they may stay in those gold plans because they're more expensive, right? It's just kind of the problem with insurance in general, is that generally the people who are sicker are willing to pony up more money to stay in. But as Tim said, we do try to mitigate that just by having the vast majority of our plans offer pre-deductible coverage. So even though you might move to a plan that has a higher deductible, you're still most likely accessing coverage that isn't subject to deductible. And so then for the cheaper premium, you can afford the higher copay. So it's just kind of the trade-off there. But I don't think that people moving to a lower metal tier are getting arguably worse coverage.
And I will pull up, and I don't know if this is appropriate. I could put a link in the chat to the task force presentation that they heard in October on this, that has some of those additional tables that then shows the example, like for somebody at a given age level and at a specific income level, what the net impact to their premiums are. And again, just, you know, just to reiterate, I mean, one of the, because it's connected to the cost of the silver plan, is that folks don't see a change in their net premium for the second lowest cost silver. So there is a chunk of folks for which, you know, they're insulated from that premium change. Okay, so to the next slide, and now we'll talk a little bit about how the task force has talked about what to do about this. The good news is that the modeling of the impact on the marketplace was not dire, but it's not zero, right? And the task force has been very clear that they don't want people to face higher premiums, and so have been talking about how to address that. And one of the things that they directed to staff, to the OHA and DCBS staff working on this, is to connect with the carriers, with the carriers who are providing coverage, who are serving the marketplace, to talk a bit more about some ideas as to how we could mitigate this impact on consumers. And so we had four meetings from September to November, and I know some of the HIMAC members were at those meetings, and it was really helpful for us to better understand the challenges facing the carriers. And one of the first ideas that the task force considered was, okay, if premiums are going to go up by $25, tax credits are going down, the federal government saves money. How do we take advantage of those savings? How do we capture the federal savings and then maybe give everybody $25 a month so that they're not seeing their premiums actually increase? And in the conversation with the carriers, and because of the limitations of healthcare.gov and the way that we would need to administer such a program, the conclusions were that it would be administratively complicated enough that this was really kind of been put to the back burner. That the, you know, both some federal challenges of capturing the dollars, as well as having the carriers be able to administer them to consumers so that it's easier on them, is just a significant undertaking without our own technology platform. So instead, the task force was supportive of, and frankly, the carriers at those meetings were also very interested in this idea of pegging the value of tax credits to the cost of the second lowest gold plan, or the lowest gold plan, instead of the second lowest cost silver plan. And so this has been referred to as the gold benchmark. And the idea is that in a lot of cases, this cost of the lowest gold plan is not that much different than the second lowest silver plan when they are silver loaded. And so this would do a good job of preserving this purchasing power for consumers. And so we've discussed this with the carriers and are currently working through this with CMS. And this next slide talks a little bit more about sort of where we are on this and what's next. So we don't know how much this would cost at the moment. And so we're working with Oliver Wyman and Manat to do at least a first blush analysis of how much this might cost to move from second lowest cost silver benchmark to a gold benchmark. And this would have to be achieved in a 1332 waiver, which we currently have for our reinsurance program, and it would have to be basically part of that same waiver. And so we're trying to figure out if basically we have enough federal pass-through dollars in that waiver to accomplish this move and have it continue to be deficit neutral for the federal government. We will not have that analysis before the task force approves their final report, which is slated for next Tuesday. So we'll continue. The direction in the current report now, or the current draft, is to continue to direct OHA to work with CMS and explore, OHA and DCBS to explore this idea. And if it does continue to pencil out to work towards submitting a waiver to do this. I think this is the last slide of this section, so we'll pause for a second if anybody has any questions on the gold benchmark concept or just thoughts more broadly. We are hoping to have at least this first feasibility high-level analysis in January.
If I can interject briefly, Drew, you
Yeah.
had a question earlier in the meeting about I think the reinsurance program and how the funds are used. This was really the only way I'm aware of it is through the gold benchmarking. But was there something else? Do you want to ask that now or save that?
It was a piece of information that I think was shared during the carrier work group, and we didn't get a chance to expand on it. And I think there was a point in the analysis where it was shared that the reinsurance program that's currently used, or funds from the reinsurance program, would be used to make the BHP whole. Like I might not be getting it accurate, but in other words, I think what I heard was that on a per capita basis, the remaining reinsurance funds left for the individual market would be lower on a per capita basis, or in other words, maybe on a current reinsurance parameters, the expected recoveries would be lower than the expected reinsurance premium or charge. And that's what I think I heard, but we didn't get a chance to delve into that more. I don't know if this is the right place to bring that up, but if that is the case, that would have an impact of, in essence, raising premiums, all else being equal in the individual market.
Okay, yeah, I was on that call too, and I didn't quite hear it the same way. And I maybe should let the others continue with this. I don't know, Lindsay, if there's anything you would add to that when you get to your piece. Okay.
Yeah, we can. I expect Tim would also have something to add on the reinsurance side too, but we can talk some more.
Okay.
Yeah, I guess just at a high level, I'll say we are also working with the actuarial team to have some analysis on sort of like what's the impact on the reinsurance program. But more so it's around if we, and I am not the reinsurance expert, right? But what do we need if we want to target the same premium reduction as in the current reinsurance program? How much is needed to do that? And then what will we get in pass through? And will that, be enough to fund what we're doing? And that pass through, especially if there's more pass through than we're investing in the reinsurance program would essentially be the funding source for the gold benchmark, because we do know that moving from the second lowest cost silver to the lowest cost gold would increase federal costs. So we have to make sure that we have enough pass through in the existing reinsurance waiver to be able to fund that move. And I know that that's not exactly what you're asking, Drew, but we can certainly try to follow up more. My understanding is that the intent is to maintain the same reinsurance targets that are maintained now.
Yeah, I heard that on the carrier call as well. And I don't know if your concern, Drew, is that we're somehow commingling reinsurance funds with the basic health plan.
No, I simply may have heard it wrong, because I thought what I had heard was that the per capita reinsurance funds reinsurance funds for the remaining individual market would need to be tapped a little bit to make the BHP whole. But if I heard that wrong, then my apologies. I didn't mean to send us on a tangent.
And there's another piece, and I'm sorry for taking this tangent if we're running short on time, but there is a piece to the BHP funding formula that accounts for reinsurance. And so I don't know if this is part of the issue, but basically there's an add-on back to our BHP funds because we have a reinsurance program, and it's like, oh, our premiums would be 8% higher, but we do this thing over here. So we get that 8% credit on our BHP dollars, but it is not an attempt to move money from reinsurance to the BHP. It's just an attempt to keep the BHP funding formula, to have some fidelity to the fact that the feds would be paying us more for the BHP if we didn't have a reinsurance program.
And Tim, this neutrality discussion, I mean, this is still being discussed and negotiated, right? This is, we don't have a final answer on these pieces.
That's correct.
Okay, great. Well, let's keep moving then. Oh, Holly, you have a question?
Sure. And, I'm not sure. I don't know exactly how this question fits into the conversation, but I'm just curious if you have any comments on, how this might affect those consumers that, with this being tied to the silver plan costs, there are some consumers that are determined eligible for a tax credit in the amount of 0, and I'm just curious how that might affect those folks.
Yeah, I don't know that I would be able to speak to that. I mean, I think in most cases, the lowest cost gold is still at least slightly higher than the second lowest silver. So there could be some scenarios where maybe folks now get a $3 tax credit instead of 0. But at the specific level, I certainly wouldn't be able to give too much more.
Okay, thank you.
I guess I will just say, in general, this is the sort of data point and the reason for lots of additional analysis as we work with CMS. We'll have to demonstrate that this move wouldn't be hurting anybody, that we have this affordability guardrail for 1332 waivers. We'll have to be able to show CMS that we're not, in the name of helping 80% of the consumers, we're not increasing premiums dramatically on 20% or something like that. So that will be part of the analysis we do, is trying to get a better handle on the impact. So next steps for where we're going, and maybe I'll just go through these two really fast. I mentioned that we had a table of representatives from each of the carriers, and we talked a lot about mitigating the impact to the market. And I think Drew and Craig and anybody else on this meeting, correct me if you don't think this is an appropriate way to say this. I think we heard a lot of support for the concept of moving to a gold benchmark. And so, we're not still meeting with the carriers, but I think as as the gold benchmark conversations go further, there certainly will be opportunities for additional discussion, and especially if we run into barriers with CMS, because it is also clear from the task force standpoint that we want to explore opportunities and options to make sure that we're not hurting consumers on the marketplace. So then the next slide, we did something very similar with CCOs to better understand the challenges that they foresee and the operational and implementation realities. And we're going to continue to meet with CCOs over the course of the next year to make sure that we're addressing their feelings and concerns and getting everybody in a place to actually implement this well. And I'll go quickly to the next slide. And so here's what the next couple years looks like. So the task force report is coming at the end of 2022, and at OHA we're starting to then develop the blueprint, which is what we submit to the federal government to operate a basic health program, and we'll be continuing to work with CMS on strategies to mitigate negative impacts to the marketplace, in particular the gold benchmark. Our target is to have a blueprint ready for submission in late spring. Before it goes to CMS, there will be public comment opportunities and a tribal consultation process, and it will go to the Health Policy Board for approval. Happy to come back and discuss further with y'all as well. And then once the PHE unwinding happens, let's say it happens in April, we move into phase 1 to keep people in the Oregon Health Plan as we get ready to move folks and stand up a basic health program. And we'll continue to work with CMS to get that approved into the summer and the fall. And then the next slide shows 2024. At some point, House Bill 4035 tells us that if we don't have approval from CMS to do something, that we have to start transitioning people to the marketplace, that temporary 1115 can't basically live forever. And so if we sometime in 2024 is probably when that would get would happen if necessary. Otherwise, moving into phase 2, which is moving again just the folks who are coming out of the Oregon Health Plan into sort of a partial BHP and getting ready for phase 3, which is the launch of the full BHP by January 2025. So all that would have to happen in late 2024 to be ready to enroll folks into that. I think that is sorry. And lastly, we do have the recommendations. These are the current recommendations from the task force. 1 through 11 were all in an interim report that was released in September, and then the 3 new recommendations that are added are to include health-related services, much like the CCOs deliver now to Oregon Health Plan members, to have an ongoing consumer engagement oversight structure that is modeled on the HIMAC and the Medicaid Advisory Committee, so something that looks like that, and for the state to continue to pursue the gold benchmark or some other mitigation strategy. But broadly speaking, the other recommendations are consistent with the direction of the bill, and given the more recent actuarial analysis, got a little bit stronger around having there be no enrollee costs and the service package that is based on what CCOs currently deliver now. So with that, I'm happy to answer more questions, and I'm sorry if we went over time.
No, that's great, Tim. I appreciate all the information, and it's an important topic. So yeah, are there questions from people?
And just to flag, I did put a link to the slide deck that has a little bit more detailed tables that I think would at least get to some of Drew's questions about the impact of folks. And then in general on the task force page on OLS, there are you can actually watch the recording of the meetings, and so you can see the actuarial team present that and give a little bit more information than just what's on the slide.
Hey, Tim, thanks for being on point. We did have Katie and Lindsay also on this topic. I just want to give them a chance if there's anything they want to add before we move on.
Katie, did you have anything where you wanted to go first? I'm sorry, I can't see you on the video now.
Oh, no, I don't have anything. Thank you.
I think just Tim mentioned the piece about governance and ongoing consumer engagement that ties to some feedback we received from this group, and some of the timing of that has a lot to do with how the PHE ends and unwinds. So I just wanted to mention that, Craig, given that this group gave feedback to the task force, and thank you to everyone for your input.
All right, great. Well, I'm sure this will be an ongoing topic for future meetings, so we'll have you back, Tim. Thanks again.
Great. Happy to come back. Thank you.
All right. So we're moving on to, the marketplace open enrollment update. That's a little out of order from our agenda. I think on the agenda we had the DFR legislative concepts. Do we have those people? We'll just move forward. Yeah. So if we have the DFR team, please introduce yourself and go ahead.
Yes, of course. Good morning, everyone. I'm Jesse O'Brien. I am the policy manager with the Division of Financial Regulation and a former member of this committee. It's always nice to have a chance to meet with all of you. So here to go over our division legislative priorities for 2023 for health. We have a number of non-health concepts because we regulate other lines of insurance and other financial products and services in addition to insurance, but figured I'd focus on our 5 health concepts this time around. So I'll try to go through this pretty quick. I think that should be doable. Maybe get you guys back some time. So our first and probably our meatiest health concept has to do with health insurance network adequacy, and that's basically our laws relating to access to care under a commercial health insurance plan, ensuring that there's an adequate network of contracted providers to provide all the covered services under a plan without unreasonable delays or long travel distances, those kinds of things. So we've had a network adequacy law in Oregon since 2015. And that law was a big step forward for consumer protection, but in the intervening years, we have seen some areas where we think it could be improved. So we are bringing that forward next year. And there's 3 major areas. First of all, we want to more explicitly call out the importance of addressing health equity and underserved communities in network adequacy, and so there will be some added provisions around that. And then also explicitly calling out reproductive health services as a set of services where we're going to be taking a look at network access. And then secondly, we're going to look at adopting stricter, more quantifiable and more enforceable access standards. Currently, our standards are relatively vague, frankly. We do have a reporting requirement that provides us with some quantitative information, but our actual standards could stand a little more specificity, shall we say. So we're looking at adopting time and distance standards as well as wait time standards. And there are actually 2 reasons for that. One is that we think it would be an improvement on where things are today, but perhaps more urgently, and this explains why we're introducing the bill this year. The CMS has indicated that they are reintroducing a federal network adequacy standard for QHPs on the exchanges, and that they will be actually stepping in and preempting states unless the states have a set of standards that are at least as stringent as the federal standards, and we are concerned that our current standards are not, and we would like to keep that work in-house. So that's one of the reasons why we're looking to do this now. And then the final provision is basically expanding our network adequacy law to apply to all health benefit plans subject to state regulation. So it currently only applies to individual and small group plans, but we do also regulate fully insured large group plans, which is actually a pretty substantial portion of the commercial health insurance market. There are also self-insured plans that we do not regulate, but there are a lot of fully insured large group plans that are not currently subject to these protections. And we do get complaints from consumers who are in those plans and are having network access issues. We'd like to have more tools to be able to respond to those complaints. So I think maybe I'll just run through all of the concepts and then take questions at the end for the sake of time. We can go to the next one. It seems like there's something that happened with the formatting of the slides here. My apologies. The next one has to do with the regulation of third-party administrators, or TPAs. This is a little in the weeds, so I'm not going to spend a lot of time on the details, but a TPA is an entity that administers health benefits on behalf of an insurer. So there might be a TPA that administers behavioral health benefits, for instance, or a self-insured employer. If you're a self-insured employer, technically the employer is the insurer. There isn't an insurance company involved, but employers hire TPAs, and confusingly, those TPAs are often insurance companies, but they're acting as a TPA in that instance. We do license and regulate TPAs, but our TPA statutes are quite old and confusing and ambiguous in some areas. And we've been getting an increasing volume of complaints around TPAs in recent years. And there are issues we see sometimes where it's unclear who's really responsible for responding to the complaint and dealing with the consumer's situation. Sometimes it's unclear who needs to be licensed. So we are just looking to make some technical clarifications around our regulation of TPAs. Can move to the next one now. And then every long session, we have a technical fix bill for health. We used to call this our ACA Reconnect concept, but since the ACA is getting further and further in the past, that's getting increasingly confusing, but we still need to have the bill. So we're calling it our Health Insurance Updates Bill now. And we're still working on this. There might be a few additional minor tweaks, but basically, the idea with the bill is to move forward what we hope are non-controversial changes to improve health insurance regulation. We have two things we're looking at right now. The first is that DFR has an old statutory limit on the number of independent review organizations we can contract with to conduct external reviews. If you're not familiar with this, an external review is kind of the last step in appealing a claim denial or another adverse benefit determination under a health plan, where it actually gets reviewed by a team of independent experts. We have the statutory limit that we can only contract with 5 of these organizations. We think that's getting to be a problem because the volume of these requests is going up, and the Federal No Surprises Act also is going to involve IROs as an important component of that. And we think that that'll increase the volume even further. And then secondly, we're looking to update the state preventive services coverage requirements to just make it up to the current day. This is the ACA's preventive services mandate. We want to make sure that that's codified in state law, in part because there is, you may have heard, a court case in Texas that where the plaintiffs are seeking to overturn the preventive services mandate in the ACA federally, and we'd like to be able to maintain those requirements here in Oregon if the federal law is struck down or changed. So that's that one. We can move to the next one. So this one can be really brief because at this point it's a placeholder. We are putting forward a bill on prescription drug pricing. As many of you know, DCBS has a couple of major programs related to drug pricing. One of them is our prescription drug price transparency program that gets reports from drug manufacturers and insurers and consumers about various data points relating to prescription drug costs. That's been in effect since the bill passed in 2018, went into effect in 2019. Still a fairly new program, still some kinks to be worked out. And then a very new program is our Prescription Drug Affordability Board, which does affordability reviews of a certain number of high-cost drugs, including at least one insulin product every year, and reports to the legislature on trends in prescription drug costs and makes recommendations to reduce the cost of drugs. We are basically going to use this vehicle for some technical changes to build on those programs, deal with some issues that have come up in implementation. We're still working on the details. It's getting a little late in the day, so we got to get those details nailed down. We actually have a stakeholder meeting next week to talk about some of our ideas, but don't want to spoil the details quite at this point. So at this point, it's a placeholder. And we have one more. I can go to the next slide. So this one will also be really quick. We have another placeholder concept related to balance billing. We are putting this forward just in case the federal No Surprises Act is overturned or seriously altered in a way that would require state action. So the background of this is, balance billing refers to what people sometimes call surprise out-of-network bills. We had a law in Oregon before the federal No Surprises Act at the state level to protect consumers from these bills and make sure that they got covered so consumers were held harmless. That law was superseded by the No Surprises Act, which passed in late 2020. And we were fine with that because the federal law is more protective of consumers in a number of respects. But there are some court challenges against the law. There's also been some discussion of changes in Congress. We have no idea what's going to happen. Just in case we need to bring back our state law or address this in some other way, we wanted to have a vehicle. So that's what the placeholder is for. But we hopefully won't have to use it. So those are our 5 concepts. I know I went through that really quickly. Anyone have any questions about any of that or anything else that I might be able to answer?
I don't see any questions, but I'll maybe ask you one briefly. So when we heard about the Oregon Health Authority legislative concepts, I think the process was it would go through what that time is Pat Allen, and then the governor signs off. Is there a similar process for what the DFR proposes? What actually ends up going forward as a bill?
Yes, we do have a similar process. DCBS has, or at least DFR has a somewhat unique process where we have a sort of internal vetting process where any staff member can suggest a concept and then they go through a kind of Shark Tank internal review with mock hearings and various other things like that. So that produces some of our concepts, but once the division knows what it wants to put forward, then it goes to our director, Andrew Stolfi. Then it goes up to the governor's office, and they have to approve. And in this case, our concepts have to be approved by the incoming governor as well. And technically, that hasn't formally happened yet. We don't anticipate a problem with any of our bills this time, which is why we're telling people about them. But it does have to get approval through the governor's office as well.
Thanks, Jesse. Well, it's good to see you again. Come back anytime. I appreciate your presentation.
Yeah, thanks for having me. And I actually have to drop off now, but I will put my email in the chat just in case anyone wants to contact me about any of this.
Okay. Thanks, Jesse. All right, the last part of our agenda this morning is an open enrollment update by Cable.
Hello. I too will try to go quickly, and as I only have a slide and a half, that shouldn't be an issue. Quick caveat, these slides were changed roughly, the 23rd hour because CMS released some new data publicly this morning. So a couple of the dates are wrong. It's actually through week 4, and the enrollment is as of 12/3 and not 12/7. That's just when they released the data. So currently, as CMS has publicly announced, we have 49,154 active enrollments. Active enrollments are those who are new to the exchange or have been set for auto re-enrollment but selected a plan instead of just letting their plan passively enroll through the normal process of just going straight through. This represents a slight decrease when compared to the same week last year, which ended on 12/4, when we had 52,379 enrollments. Again, we can go to the next slide. That's one fewer day for this open enrollment, and when averaged out, we're roughly at 97% of last year's pace for plan selections at the same time. So pretty similar to where we were last year at this time in open enrollment. And, given an election happening this year and all the public outcry around that and the decision to wait to kind of start our marketing and advertising until after the election cycle had ended, so we weren't competing with those advertising slots, it's not a huge surprise that we're, a teeny bit shy, even though it's virtually the same as previous years. And I'm happy to answer any questions that people might have. For those of you who are new to the committee, this is much more detailed than we've actually been able to release in the past. Normally, CMS embargoes all these numbers, and they're a secret until about, I don't know, April of the following year. So we've usually been pretty vague on what we've been able to tell folks. And so this is a nice kind of change of pace to be able to give you some actual numbers on where our enrollment stands during open enrollment. Good. I'm going to take that as I did a great presentation. No questions, everyone's answered, and I'll let us move on to our next piece with the open enrollment updates.
Hi, everyone. Katie Button, Plan Management. As you know, we have a standalone plan display. We call it window shopping. And so these are the numbers for our window shopping. We launched on October 24th. So these numbers are October 24th through December 1st. So we've had over 18,000 unique users already. I believe that's actually a little ahead of where we were last year. Each user spends about 5 minutes using the tool, which is really good. That means that they're actually really looking at plans and seeing what's out there for them. And then for our most popular plans, there are 5 bronze plans. Those are the plans that people are looking at. Which is fine. I think, we all like to see people looking at a variety of coverage, but those bronze plans are the least expensive. And that's why we work really hard to make sure that they have pre-deductible coverage. The most popular plan was viewed 657 times by 412 users. So people are going back and looking at plans again, which is also a good sign that they're really using the website to compare and contrast the plans. And then this year, we rolled out the Affordable Employer Coverage tool, which is to address the correction to the family glitch. So as of 12/1, we've had 600 users who have access to that tool. And I'm happy to answer any questions if there are any. All right, next up, take it away.
Hello, it's Miranda again, Community Partner Liaison here. We just have an amazing, robust network of community partners that we are so fortunate to partner with this year. We were able to bring forth our partnerships from last open enrollment that you can see here on the screen, and then we were able to add a couple more to address some focus populations and communities that we're really hoping to extend our outreach to, such as UNATE and Mosaic, and also Central Latino Americano. They're new to us this year, and we're really excited to have them. And they are all grantees with our regular community partner program. And then because we were able to receive additional grant funds for the modernization grant, we also were fortunate to bring on 4 additional community partners to address other focus communities or communities of focus. And we're just really happy to have them be partnering with us, and we're just doing great work out in the field during open enrollment, and they've all reported back to us that things are going smoothly and they are able to successfully reach all of the communities that they're reaching out to. Does anyone have any questions on our current partners before I move on to the next slide? So here is a visual of the communities that our robust network of partners are able to extend their outreach to with their expertise. It's just amazing to me when I get the reports every month of all of the fantastic work they're doing. So if you look here, it's really robust. So on the right-hand side, I broke it down into geographically, where we're able to really dive into the outreach with these community partners. And then the green, I'll call it greenish color, those are the communities that we're really able to extend into because we've partnered with these wonderful organizations. And then I just wanted to give an update. So far, so we receive monthly metrics every month that shows the great work that our partners are doing. So like I said, everything's going smoothly. Our grantees are excelling and providing outreach to communities of focus in Oregon. And here's just some numbers that we have. It's absolutely outstanding. Our outreach contacts are over 3 million. People reached on social media platforms, 107,000 plus. The network meetings that they've attended to spread the word about Marketplace open enrollment and all the coverage options for people. Over 124 networking meetings. And then of course, outreach materials that have been distributed, 8,572. This is absolutely amazing. So that's my update on our community partner program. And they're just out there, boots on the ground, doing fantastic work for Oregonians and making sure that they have the information they need and access to affordable coverage.
Thank you, Miranda and team. So is this the final slide for open enrollment updates? So thank you very much. So aside from our community partners, of course, we also have our fantastic network of insurance agents. Due to the limited amount of time, that was on me. I asked not to include that for this time, but we'll be happy to bring that as part of our open enrollment debrief in January. So as we all know, right, open enrollment is still very much ongoing, so much so that I believe we lost Gladys Batwell to her work because, we were counting down to the last few days before January 1st coverage starts. So in case you have friends or family, if we have members of the public join, please do encourage folks to sign up for their health insurance plan, their private health insurance plan by December 15th for January 1st coverage. These numbers that you have in front of you will only go up because our work is far from done. We still have more than a month before open enrollment ends, and we will still definitely be hitting up every channel, every community of focus. All our advertising campaigns will still be ongoing, and we're coming back in January to provide an open enrollment debrief, wrap up, update for you all. But in the meantime, should you have any questions, please do let us know.
Thank you for that. We're a little bit ahead of schedule. I'm just curious, before we close things up or take public comment, I would like to know from our agent and community partners if they have any comments about this year's open enrollment compared to last year or previous years. Anybody wants to offer anything up?
Greg, if this is helpful, I have heard from certain community members that they love our actor that we use for our OregonHealthcare.gov commercials. So if you haven't seen them in your local channels, I'm sure they'll pop up in your social media channels somehow, some way. We are everywhere, thanks to Amy and Coach Kokus. I just get random snippets from folks from my community, like, hey, this is you and your team, right? So I am happy to hear and see that the news is the awareness is building and that they love our actor. I know he's not Jake from State Farm, but I try not to say his personal name out loud in a public setting. So we are very pleased with our ads this year, and so far so good.
And I'll just, oh, go ahead, Craig.
No, I was just gonna make a comment about watching too much television. I do appreciate him, and it's a refreshing after all these political ads too. So I can actually watch with the sound up. Go ahead.
I was just going to share that, you know, as a community partner, we feel like open enrollment's been going really well, and we are glad to see that the extra savings are continuously available. I've also seen the trend where consumers that previously enrolled in gold plans decided to go with a silver plan because of the, you know, just some of the, they got the same benefits, even though they were looking at, you know, shifting their tier level. They did, you know, it's just kind of aligned with that discussion we were having earlier as to why people may decide to go with a silver plan instead of a gold plan. So, yeah.
Okay, so they're on that point, they maybe save some premium, but they're not seeing the same impact on the benefit side. So
Right, yeah, they were comparing plans and seeing that, you know, a lot of the benefits were pre-deductible covered. So yeah, that kind of helped their decision to go ahead and go with a silver plan, even if the deductible was a little higher.
Thanks, Holly. I think before I wrap up, I just had one question for Cable. We kind of ran through his slides quickly. And you mentioned the 49,000 people who have done, I guess, active enrollment one way or another, but there's clearly a lot more people in the marketplace. So many people auto re-enroll and maybe don't touch their plans and just renew because they've done that. Do you have a sense of how many people elect to auto re-enroll? Does that change over time?
Yeah, so conveniently, I actually have a spreadsheet up here from last year's CMS information. So last year when we had 146,000 enrollees, of those, 117,000 were re-enrollees, so re-enrolled. Of those, 83,000 or almost 84,000 had an active re-enrollment, which means they went in, shop for plans, and whether or not they remained on the same plan, they at least actively selected a plan. So it could have been the same plan they were on, or maybe they switched to a different plan. And 33,000, almost 34,000 passively re-enrolled, which means they didn't go in, look at any plans or anything like that. They were comfortable where they're at and then renewed their same policy or plan on January 1st. And we had 29,000 new consumers as well last year. And new consumers is kind of a misnomer in some cases. That includes anyone who is completely new to the exchange, but also those who maybe had a plan that they terminated prior to October 31st and then came back in and enrolled again. So new consumers is always kind of a batch of very new and somewhat new, and maybe those who had a plan but just didn't keep it throughout the entire year, which is pretty typical on the marketplace, that we see our highest effectuated enrollment numbers January through March, and then April through December it tends to taper off as, you know, people may just feel they don't need their insurance coverage. They got their checkup, their doctor said they was healthy. They said, well, we don't need to pay for insurance, or whatever the case might be.
Okay, so a large majority of people do at least look around, which is something that I think we encourage. And probably this year with some of the larger premium increases going into 2023, we should see that number increase. So as you said, maybe we're just a little bit further behind this year.
Yeah, and it's always hard to gauge. You know, one day we could see 6,000 people, another day maybe only 500 with holidays and everything and people's schedules. It's always sort of hard to really gauge until that final number comes out where we were at, and we're pretty close to where we were last year, though. That being said,
Thanks, Gable.
not a problem.
All right, I think that brings us to public comment. So I'll open it up again. Public comment. Well, I'm not hearing any or seeing any, so I think we can move on from public comment and do closing. And I guess the good news is you're going to get a few minutes back this morning. But before I let you all go, I just again want to thank everybody for your time on the committee. This is important work, and please, if you have any feedback on these meetings, don't hesitate to reach out to me or Lindsay or Chicky or anybody on her staff. And I want to thank everybody who presented this morning as well. You know, it takes time out of their schedules. And again, thank you for your time and look forward to seeing you next time. And oh, lastly, happy holidays to all of you, since those are coming up. Enjoy time with your family and friends. See you all later.
Thank you, Craig. Thank you, everybody.
Thanks.